Hello, students. Welcome to Concepts of Care for Patients with Biliary Problems and Pancreas Disease. Okay, so we are in part 4. We're going to talk about chronic pancreatitis. We discussed already cholecystitis, acute pancreatitis, and this is part 4 of this chapter, chronic pancreatitis. What happened is part 1 and part 2 is cholecystitis, okay? Part 3 is going to be was acute pancreatitis, and now we have part 4, chronic pancreatitis. So as usual, we start with the video to get a better understanding of what's going on with this chronic pancreatitis.
Chronic pancreatitis. Chronic pancreatitis is caused by long-term inflammation of the pancreas, which eventually leads to the irreversible destruction of pancreatic tissue. Chronic pancreatitis develops slowly over time and is predominantly triggered by lifestyle factors in predisposed patients, such as long-standing heavy alcohol or tobacco use, although this is not always the case. Other less common causes are medications that put stress on the pancreas, elevated triglycerides, some autoimmune conditions, and some inherited or genetic conditions, notably cystic fibrosis and hereditary pancreatitis. In some people, the cause of chronic pancreatitis is never discovered and remains a mystery. The pancreas is a digestive system organ that has two important functions. It produces hormones that regulate blood sugar, as well as enzymes to break down food in the digestive tract. When the pancreas doesn't work properly, it affects the body's ability to properly digest food. This means that some people with chronic pancreatitis are unable to get the nutrients they need from the food they eat. They can have trouble digesting food properly or maintaining their blood sugar in a healthy range. This can lead to nutrition-related disease such as weak bones and vision loss. Some people may also have difficulty gaining or maintaining their weight and persistent pain. The hallmark symptom of chronic pancreatitis is abdominal pain. The pain may be intermittent or chronic and is frequently very severe, with stabbing pains localized in the upper part of the abdomen between the belly button and the chest. The pain may radiate to the back and may be triggered by eating, especially high-fat foods. As the disease progresses, the pain may become more severe and debilitating, and often it becomes constant. In some cases, surgery or endoscopic treatment may be required. Oily, foul-smelling bowel movements and weight loss may be seen in the advanced stages of the disease, and usually signals exocrine pancreatic insufficiency. As well, depending on the severity and extent of the damage to the pancreas, some people develop diabetes. A combination of tests are used to diagnose chronic pancreatitis. In some people, diagnosis is challenging due to the course of the disease. However, in others, it is relatively straightforward. A CT scan of the abdomen is the most commonly used test. An MRI or endoscopic ultrasound may also be used to confirm the diagnosis. In some difficult-to-diagnose cases, pancreatic stimulation testing can be useful. This test artificially stimulates the pancreas using secretin. This test is expensive and invasive, so it is not frequently performed. Blood tests are not useful for diagnosing chronic pancreatitis. Although there is no cure for chronic pancreatitis, early diagnosis and treatment can help slow the progression of the disease. Treatment involves avoiding triggers, such as heavy alcohol use, smoking, and high-fat foods. Other treatment interventions involve pain management, medication such as pancreas enzyme replacement therapy, PERT, and supporting a healthy diet with multivitamin and mineral supplements.
Thank you so much. That was an excellent review of the condition. Really excellent. Chronic pancreatitis is a progressive destructive disease of the pancreas that has remissions and exacerbations, flare-ups. Okay, some of the patients sometimes when they develop acute pancreatitis and they are lucky to reverse the condition, right? Because they minimize the causative agents, then they suddenly, little by little, go back to those bad habits, and then they are having remissions and exacerbations. Okay, so inflammation and fibrosis of the tissue because of these remissions and exacerbations contribute to pancreatic insufficiency and diminished function of the organ. It's like going back and forth, back and forth. I'm healing, I'm getting worse. I'm healing, I'm getting sick. I'm healing, and these remission and exacerbations are the one causing this fibrosis. Chronic pancreatitis can be classified into several categories. So you have alcoholism is the primary risk factor for chronic calcifying pancreatitis, which is your CCP, chronic calcifying pancreatitis, and that is the most common type. So then you have the intraductal calcification and marked pancreatic tissue destruction, necrosis, develop in the late stages. Intraductal calcification and marked pancreatic tissue destruction. The organ becomes hard and firm as a result of cell atrophy and pancreatic insufficiency. So your chronic calcifying pancreatitis, your CCP, is found predominantly in men. Think about the alcohol, the cigarettes, right? The high intake of high fatty foods. So, but the incidence in women is increasing. Chronic pancreatitis occurs more commonly among those with biliary tract disease, cholecystitis, and cholelithiasis. Just to refresh, cholecystitis is the inflammation of the gallbladder, and cholelithiasis is the formation of gallbladder stones. Chronic obstructive pancreatitis develops from inflammation, spasm, and obstruction of the sphincter of Oddi, often from cholelithiasis, the gallstone. And again, the sphincter of Oddi is the sphincter that is between the duodenum and the common bile duct. And the common bile duct is the tube that receives three other different branches. One is coming from the hepatic source, the liver. The other one is coming from the bile duct, which is a tube coming from the gallbladder. And the other one, and the third one, is a tube coming from the pancreas. The three branches get together in the common bile duct, and then they find the sphincter of Oddi, which is the the entrance door. Well, is the exit for the common bile duct, but at the same time is the entrance door to the duodenum. Okay, so is going to cause an obstruction of the sphincter of Oddi, often from cholelithiasis, from gallstones. Okay, so autoimmune pancreatitis, this is another type. It's a chronic inflammatory process in which immunoglobulins may invade the pancreas, right? So other organs may also be infiltrated, including the lungs and the liver. So other organs may also be infiltrated because of the proximity between the pancreas and the diaphragm that is below the left lung. Okay, there is evidence to show that autoimmune pancreatitis puts the patient at risk from pancreatic cancer. Autoimmune pancreatitis because the organ starts eating itself out to digestion, right, through different enzymes, lipase, amylase, protease, and also those are the enzymes from the exocrine activity of the pancreas, while the endocrine is the one that produces hormones to regulate blood glucose, right? So idiopathic, we have another type. Idiopathic and hereditary chronic pancreatitis may be associated with SPINK1 and CFTR gene mutations, and with mutations in the BRCA2 gene. BRCA2 is related to the breast cancer, right? People with hereditary pancreatitis have been shown to have a 53-fold increased risk of pancreatic cancer. So those with those genes have 53-fold increased risk of pancreatic cancer. Pancreatic insufficiency in any type of chronic pancreatitis causes loss of endocrine functions. So is the exocrine function. Pancreatic enzyme secretion must be greatly reduced to produce steatorrhea. Pancreatic enzyme secretion must be greatly reduced to produce steatorrhea, resulting from severe malabsorption of fats. These characteristic stools are pale, bulky, and frothy, and have an offensive odor. So that's one of the symptoms that I will look in this chronic pancreatitis, this offensive odor, right? Stools are pale, bulky, and frothy, and have an offensive odor. And that's good to know. And I'm sure you're going to have those characteristics in NCLEX, okay? So that's good to know. NCLEX alert. The action of colonic bacteria on unabsorbed lipids and proteins is responsible for the extremely foul odor. On inspection of the stools, the fat content is visible. Okay, let me put it in. That's good to know. Fat malabsorption also contributes to weight loss and muscle wasting. So to visualize, so you have your enzymes in the pancreas that are not working properly. This exocrine activity is not working properly, lipase, protease, and amylase, right? And on top of that, you are going to have the problem with the malabsorption of fats, probably coming from the imbalance, or there is a lack of activity producing the bile duct that causes steatorrhea. Okay, so fat malabsorption also contributes to weight loss and muscle wasting, a decrease in muscle mass, and leads to general debilitation. Protein malabsorption results in a starvation edema of the feet. Let me complete this part that we need to remember this part about the offensive odor. That's for sure one of the characteristics. So fat malabsorption also contributes to weight loss and muscle wasting, a decrease in muscle mass, and leads to general debilitation. Protein malabsorption results in a starvation edema of the feet, legs, and hands caused by decreased levels of circulating albumin. So there you go. You have another good sign of chronic pancreatitis. So you're going to see this patient coming with edema on the feet, the legs, the hands, caused by decreased levels of circulated albumin, okay? Because the protease, which is a enzyme of the pancreas, is not working properly to absorb that protein. And then you have fat malabsorption. You're having problems with lipase as well, right? Okay, so you have malodor, you have bad protein absorption. Now the loss of pancreatic endocrine function is responsible for the development of diabetes mellitus in patients with chronic pancreatitis insufficiency. So before talking about the protein and talking about the fat malabsorption, we were talking about the exocrine activity, right? 3 enzymes. Again, let me repeat, because this is repetition make you understand. Okay, so we have lipase, protease, and amylase. The three of them are exocrine enzymes of the pancreas, and inside is the endocrine. That's the one controlling the glucose, right? And that's the one related to the diabetes type 2. The patient with chronic pancreatitis may have pulmonary complications such as pleuritic pain, pleural effusion, and pulmonary infiltrates. And we know the definition of that, right? Pancreatic ascites may decrease diaphragmatic excursion and lung expansion. When we talk about ascite, means the collection of fluid. So this pancreas is going to collect fluid affecting the surrounding. It's going to push the diaphragm upwards and is going to reduce the expansion of the lung, resulting in impaired ventilation. In the ill patient with chronic pancreatitis, acute respiratory distress syndrome may develop. So that's another factor. There you go. In those 4 or 3 paragraphs, we are having definitely a lot of characteristics in the presentation, right? We see a patient in ER coming with acute pain, and we are seeing the edema in the feet, the legs. Then we're having problem with the respiratory function, and then we are having this offensive odor, right? So that's the entire picture for chronic pancreatitis. And then when we do the assessment and the history, are going to find that the patient was having high intakes of high fat food, is drinking a lot, and is smoking a lot, right? Okay, very good. So assessments. For those with chronic pancreatitis, pain is typically described as a continuous burning or nagging dullness with periods of acute exacerbation flare-ups. The pain is very intense. The frequency of acute exacerbation may increase as the pancreatic fibrosis develops. So we are going to see that fibrosis in the imaging, but not in the physical presentation when the patient comes to ER. Abdominal tenderness is less intense in patients with chronic pancreatitis than in those with acute pancreatitis, and that's a good difference, right? Massive pancreatic ascites might be present, producing dullness on abdominal percussion. Because respiratory complication can occur, auscultate the lungs, feel for adventitious sounds, or decrease aeration, and observe for dyspnea. So we're going to see a patient that is going to lose weight unintentionally. He's going to report that he lost a lot of weight, that he is having jaundice, dark urine, and the symptoms of diabetes mellitus, such as polyuria, polydipsia, and polyphagia. Okay, so that's another piece of information that is going to, so we have steatorrhea, jaundice, the polyphagia, polydipsia, polyuria, offensive odor, the edema, adventitious lung sounds. So the whole presentation is telling you chronic pancreatitis. Okay, now diagnosis is based on the patient's symptoms of laboratory and imaging assessment. We have endoscopic retrograde cholangiopancreatography, right? We have discussed this many times about how this procedure is done. And this procedure is going to check the pancreatic and common bile ducts. Also, we are having a CT scanning with contrast, MRI, abdominal ultrasound, and endoscopic ultrasound. All these type of imaging being ordered depending on the presentation. In chronic pancreatitis, laboratory findings include normal or moderately elevated serum amylase, which breaks down the carbohydrates, and lipase, which breaks down the fats, right? The lipids. Obstruction of the intrahepatic bile duct can cause elevated serum bilirubin, and we already discussed how the bilirubin is processed, right? So we are talking in this case, it's going to be, would you need to differentiate between unconjugated bilirubin versus conjugated bilirubin. The conjugated is going to be inside of the liver, right? So the key features: chronic pancreatitis, intense abdominal pain, abdominal tenderness, ascites. We don't see this in acute pancreatitis. Ascites is a different symptom. Possible left upper quadrant mass if pancreatic pseudocyst or abscess is present. Respiratory compromise, staturia, clay color stools, weight loss, jaundice, dark urine, and with staturia also we're going to talk about the foul odor in the feces. Polyuria, polydipsy, polyphagia, we don't see this in acute pancreatitis. So besides elevated bilirubin, we're going to see also elevated alkaline phosphatase levels, intermittent elevations in glucose, and can be detected by blood glucose monitoring, both fasting and non-fasting. So it's not relevant really the fasting state of the patient. The glucose is going to be awkward. Non-surgical management. The primary non-surgical intervention include drug and nutrition therapy. So major intervention for the pain of chronic pancreatitis is drug therapy. That's the only way they are going to manage that, with opioids. Pancreatic enzyme replacement therapy, PERC, is the standard of care to prevent malnutrition, malabsorption, and excessive weight loss. Pancreatic enzymes are usually prescribed in the form of capsules or tablets that contain varying amounts of amylase, lipase, and protease. These teach the patient not to chew or crush the enzymes replacements that are available as delayed release capsules or enteric tablet. Teach them to take the enzyme with all meals and snacks. And this is good to know, and this is going to be NCLEX alert. So I'm going to repeat. That's good to know. NCLEX alert. Remember that NCLEX is going to test you in everything related to nursing education, nursing care, post-procedures, pre-procedures, right? Patient education is crucial, especially when it comes to pharmacologic methods, okay? So you need to teach patients not to chew or crush pancreatic enzyme replacement that are available as delayed release capsule or enteric tablet. What does it mean, delay release or enteric tablets? That those capsules are done in such a way that they are going to dissolve in the small intestine, okay? Specifically, where the pancreas, the gallbladder, the liver, all together in the common bile duct are going to enter the duodenum, okay? So that capsule, that tablet needs to get perfect to that area. It's gonna go through the esophagus, the stomagus, it's gonna go through the lower esophageal sphincter, the stomach, the pylorus, and it's going to receive all the enzymes from the liver, the gallbladder, maybe some enzymes from the sick pancreas. Is going to travel through the common bile duct and entering through the sphincter of Oddi to the duodenum. Okay, so I gave you the pathway. Imagine that capsule. If you chew that capsule, the enzymes are not going to be absorbed in the place they need to be absorb. Okay, so these are replacement. They are going to help you absorb the fats, the lipase. Amylase is going to help you absorb the carbohydrates, and the protease is going to make you absorb the proteins. So nursing, safety priority, action alert. If the patient has diabetes, insulin or oral anti-diabetic agents for glucose control, glucose control are prescribed. Patients maintained on total parental nutrition are particularly susceptible to elevated glucose levels and require regular insulin to the solution. So here you have a patient that is receiving TPM, total parental nutrition, and we know that nutrition is given through intravenous, right? It's not enteral, it's intravenous. Therefore, due to the components of that total parental nutrition that has some carbohydrates on it, the glucose that is already acquired in this chronic pancreatitis is going to be even higher right now with the total parental. So the only way to control that is to administer insulin to the patient. Okay, you glucose monitor, administer insulin to the patient. So you need to monitor for that. Monitor blood glucose to control hyperglycemia. Check finger stick blood sugar every 2 to 4 hours. Okay, the primary healthcare provider may also prescribe drug therapy to decrease gastric acid. Gastric acid destroys the lipase needed to break down fats. Okay, controlling the acidity of the stomach with H2 blocker or proton pump inhibitors, right? Or neutralizing stomach acid with oral sodium bicarbonate may enhance the effectiveness of PERCs. So all these drugs are going to work together to make those enzymes PERT more effective. Okay, so collaborate with the registered nutritionist to teach the patient about long-term dietary management. Again, PERT means pancreatic enzyme replacement therapy. Pancreatic enzyme replacement therapy. So you're going to collaborate with the nutritionist to teach the patient about the long-term dietary management. This is a long-term, and it's going to be it's a complete change in the dietary habits. Okay, there's no return. Either you follow the diet or everything is going to get worse. So here she needs to increase a number of calories up to 4,000 to 6,000 calories per day to maintain weight. Remember, these patients lost a lot of weight. Food high in carbs and protein also assists in the healing process. We need protein to repair or damaged cells, and we need carbs in order to provide energy to the body, right? So the patient lost weight, he's in extremely fatigue, so he needs energy sources. Food high in fats is avoided because it causes or increase diarrhea, right? And it's going to increase the foul odor of the bowel movement. Teach all patients to avoid alcohol. Well, alcohol cessation program may be recommended. Surgical is not a primary intervention for the treatment of chronic pancreatitis. However, it may be indicated for ongoing abdominal pain, incapacitating relapse of pain, or complications such as pancreatic abscess or pancreatic pseudocyst. So other approach is going to be the laparoscopic, right? If the pancreatic duct sphincter is fibrotic, the surgeon performs a sphincterectomy, incision of the sphincter. So it's going to enlarge it. The approach is going to go through the sphincter. Endoscopy, sphincterectomy may be used for patients who are poor surgical candidates. So now transition to home care management. Teach patient and families to that toilet facilities may be easily accessible because of chronic staturia and frequent defecation. This patient needs to be close to a restroom. Even when the patient goes out, they need to planify. Okay, we are going to the mall. Where is the bathroom? Is there any 2, 3 bathrooms in this level? Another restroom in the second level. Then we are going to the restaurant. Is this restaurant having? We need to planify. Okay, self-management education, because there is no known cure for chronic pancreatitis. Patient and family education is aimed at preventing acute episodes of the disease, providing long-term care, and promoting health maintenance. So basically, if the patient adheres to the non-alcohol, non-smoking, no high-fat diet, and the patient gets the pancreatic enzyme replacement therapy, and the patient follows the dietary nutrition, high proteins and carbohydrates, um, and lots of water, right? They can prevent acute episodes of the disease. So preparing for self-management, prevention of exacerbation, avoid things that make your symptom worse, such as drinking caffeinated beverages, avoid alcohol, avoid nicotine, eat bland, low fat, high protein, and moderate carbohydrate meals, avoid gastric stimulants such as spices. Eat small meals and snacks high in calories. Remember, these patients are going to keep losing weight until they understand they need to change their diet, definitely. Take the pancreatic enzymes that have been prescribed for you with meals so you can absorb the foods you are getting now. Rest frequently, restrict your activity to one floor until you regain your strength. Preparing for self-management, take pancreatic enzymes, administer enzymes after antacids or H2 blocker, decrease pH, inactivates drugs. So this is one of the things that for sure is going to come in NCLEX, how the patient needs to get their pancreatic enzymes replacement therapy, administer these enzymes after antacids or H2 blocker. Okay, decrease pH, inactivates the drug. So this is something that's good to know. Okay, NCLEX alert. Yes, the questions in NCLEX are, as I told you, I think is 30 to 35% pharmacology. You need to know the ways you provide patient education related to the drugs. Okay, so that's good to know. Okay, NCLEX alert. NCLEX alert. Okay. So swallow the tablets or capsules without chewing to minimize oral irritation, and allow the drug to be released slowly. Okay. Do not mix enzymes preparation in protein containing food. And these are very good sources, so you can go back and review this for your patient education sessions. The frequency of defecation, whether continent or incontinent, poses challenges, skincare problems. Correct. Instruct the patient to keep the skin dry and free of the abrasive fatty stool which damage the skin. Okay, so now if the patient develops diabetes mellitus as a result of chronic pancreatitis, management of elevated glucose levels after discharge from the hospital may require oral anti-diabetic agent or insulin injection. So this chronic pancreatitis at the end is going to cause, in some cases, diabetes in the patient without having the original cause of the insulin resistance, right? It's just for the alcohol. The alcohol is causing this and this, and the smoking. Okay, so now we are switching to pancreatic cancer, which is the last step in this lecture related to pancreas. So let's watch this video to see what's going on in this latest stage of the chronic pancreatic disease.
Pancreatic cancer, treatment and outcomes. Pancreatic cancer affects the pancreas, a digestive system organ located in the upper abdomen. The pancreas has two important functions. It produces hormones to regulate blood sugar and enzymes to break down food. Treatment of pancreatic cancer is divided into two approaches: curative and non-curative, or palliative. Curative treatment is possible for localized tumors which are amenable to surgical removal. Most pancreatic cancers are in the head of the pancreas. Tumors in the head of the pancreas are removed using a surgery known as the Whipple procedure. In this surgery, the head of the pancreas, the distal bile duct, and some of the small intestine are removed. It also involves some reconstructive surgery. A Whipple procedure is a major surgery that takes 3 to 5 hours and typically requires a 7 to 10 day hospital stay. The operation is best performed by specialized surgeons. If the tumor is in the body or tail of the pancreas, a distal pancreatectomy surgery is performed to remove these parts of the pancreas, as well as the spleen, and sometimes part of the stomach. Very rarely, in the case of large or multiple tumors, the entire pancreas is removed, together with the gallbladder, part of the bile duct, the duodenum, and part of the stomach and spleen. Reconstructive surgery is then performed. Following surgery, chemotherapy is given to help destroy any remaining cancer cells in the body. Radiation treatment may also be used to target remaining cancer cells in the pancreas. Recovery after surgery can be slow. Following a Whipple procedure, the stomach empties more slowly, which can result in nausea, vomiting, feeling full quickly, and poor nutrition. However, this improves over time. As well, infections and leakage of pancreatic juices are common during the healing process. Weight loss over the first 3 to 4 weeks following surgery is typical. If the tumor is not operable, then treatment is non-curative or palliative in intent. Rather than attempting to cure the disease, the goal of treatment is control of the disease, extension of life, symptom relief, and maintaining quality of life. Chemotherapy and radiation may be used to slow progression of the cancer, and medication to manage pain is common. Long-term outcomes following curative treatment vary immensely. Even after successful surgery, chemotherapy and radiation, pancreatic cancer returns in most cases. Between 15 to 40% of people who undergo surgery live for 5 years or more. However, on average, the cancer returns in about a year, and survival is between 1 to 2 years post-treatment. Nutrition is important in both curative and palliative treatment plans. Decreased appetite and feeling full early are common. As well, the pancreas loses its ability to work well. This may affect how nutrients are absorbed from food and its ability to regulate blood sugar. To help maintain weight and nutrition, the treatment plan may include pancreatic enzyme replacement therapy, PERT, nutritional supplements, and appetite stimulants. Dietary changes to reduce the amount of fat in the diet may also be recommended, as well as increased frequency of small meals or snacks.
Thank you very much. So you got the entire perspective perspective of what is pancreatic cancer, right? Is the leading cause of cancer deaths each year in the United States. And you need to understand that if the pancreas is having cancer, meaning that the enzymes that help you absorb the nutrients, amylase, lipase, and protease, are going to be compromised. And if they are not working, the patient is going to start losing weight, too many pounds, too many kilograms. Okay, so then on top of that, you are having the diabetes, the glucose is going up. And we know that the cancer fits based on glucose. Okay, so it's a um, never ending story. It's a domino effect. So pancreatic cancer is a terminal illness. Okay, most often the tumor is discovered in the late stages of development and may be a well-defined mass or diffuse spread throughout the pancreas. So treatment has limited results and 5-year survival rates are low. 5-year survival rates are low. That's what I was going to add to the video. I've seen 1 year, 1.5 years, 2 years the most. Okay, the tumor may be a primary cancer or it may result from metastasis from cancers of the lung. Remember all the lymph nodes that are around these organs. These organs are very close to each other, right? So we have a metastasis from cancer of the lung, breast, thyroid, kidney, or skin. Primary tumors are greatly adenocarcinomas and grow in well-differentiated glandular patterns. They grow rapidly and spread to surrounding organs like the stomach, duodenum, gallbladder, and intestine. So that's why when the Whipple procedure takes place, sometimes they need to remove parts of other organs, not only the lymph nodes around, but part of other organs in order to clean the area and try to reduce the progression of the disease. They grow rapidly and spread to surrounding organs, the stomach, duodenum, by direct extension and invasion of lymphatic and vascular systems, as I was telling you. And there is two things. The lymph nodes are going to carry these cancerous cells to other organs, but you have to remember that cancer not only feeds from glucose, from sugar, but also every time there is cancer present in the body, the tumor, the cancer itself, is going to create vascularity, because through the vascular system, the cancer get its food, the nutrients. So they are going to create their own network of circulatory. Okay, this highly metastatic lesion may eventually invade the lung, peritoneum, of course, which is the bag that holds all the organs in the abdomen, liver, spleen, and lymph nodes. Okay, the head of the pancreas is the most common site for pancreatic cancer. Jaundice results from tumor compression and obstruction of the common bile duct and for gallbladder dilation, causing the organ to enlarge. Cancer of the body and tail. Let's remember that the body is very close to the gallbladder. The head of the pancreas is very close to the gallbladder and the common bile duct and the duodenum. And the body and tail is kind of in the middle of the abdomen, and to the tail is toward the left side of the body. Okay, so cancers of the body and tail of the pancreas are usually large and invade the entire tail and body. These tumors may be palpable abdominal masses, especially in the thin patient, and it's not difficult to palpate the tumors. Remember, the patient lost a lot of weight. Venous thromboembolism is a common complication of pancreatic cancer. Necrotic products of the pancreatic tumor are believed to have thromboblastic properties, resulting in the blood's hypercoagulable state. The exact cause of pancreatic cancer is unknown. But we know that whenever we consume a lot of alcohol and nicotine, this alters all the functions and metabolism in our body, right? So risk factor associated with pancreatic cancer, diabetes mellitus, chronic pancreatitis, cirrhosis, which is also most of the cirrhosis is based on alcohol, high intake of red meat, especially processed meat. We discussed this previously in colon cancer. The American Cancer Society finally released a statement about the red meat and its relation with the carcinogenic nutrients, right? Long-term exposure to chemicals such as gasoline and pesticides. Okay, so all these ladies and gentlemen that are putting pesticides all over, right? And they are kind of putting themselves in risk for pancreatic cancer. Obesity, of course, older age, and we know that obesity is a chronic inflammatory state, male gender, cigarette smoking, family history, genetic mutations. So pancreatic cancer, the key features, you're going to see jaundice, icterus, clay color, light stools, dark urine, abdominal pain, anorexia, nausea, vomiting, glucose intolerance, splenomegaly, which is the enlargement of the spleen, which is on the left side next to the pancreas. And this enlargement must be done. The assessment must be done by a primary care provider. Okay, nurses do not touch the spleen. Don't try to assess the spleen because you can cause a spleen rupture. You don't want to do that. It's not under your scope of practice. Flatulence, remember the full odor, bowel movement, gastrointestinal bleeding, new onset diabetes mellitus, ascites, the abdominal fluid. This is a hallmark of the presentation of pancreatic cancer. Lack of calf pain from thrombophlebitis, weakness, and fatigue. So assessment, pancreatic cancer often presents in a slow and vague manner. Okay. Okay, yes, I wanted to share with you, even though I did this in class, about thrombophlebitis and how you can assess a patient that is having a blood clot. This is a Homan signs. Let's watch this video so you, since I share too many videos about signs, how you can assess, let's watch this one, okay? It's very important.
Another special test when we're dealing with the lower extremity, certainly with a patient that may have been immobilized for a great deal of time or who's having vascular problems, maybe had post-surgery. Patient that's coming out of the hospital with total knee replacement or total hip replacement, joint replacement in general. You always want to go and test the Homan sign. This is going to test for a DVT, for a deep vein thrombosis that may take place in the lower extremity. If that takes place, all you're going to do is kind of take the foot up into neutral position, or dorsiflex the foot, and I'm going to palpate and squeeze at the gastroc soleus. If this is positive, it'd be quite painful. This is going to test the integrity to see, make sure that there's not a DVT in the lower extremity. This one is the Homan sign.
Thank you very much. So it's not only for patients that went through knee replacement or hip replacement. It could be a patient that just delivered a baby, post-delivery, and maybe had is in the hospital for 3 to 4 days, and you need to promote ambulation, and you always need to test for Homan sign. These patients with pancreatic cancer are going to be in a hospital in bed, recovering from the pain, and since they are not doing ambulation, they lost a lot of weight, they have a lot of fatigue, probably they're going to be bed rest, right? So you need to assess for that. Is very important. Now, recognizing the cues, No specific blood tests are diagnostic for pancreatic cancer, as we saw in the video. So serum amylase and lipase level and alkaline phosphatase and bilirubin levels are increased. The degree of elevation depends on the acuteness or chronicity of the pancreatic and biliary damage. Elevated carcinoembryonic antigen CEA levels occur in most patients with pancreatic cancer. So there you have your CEA. This test may provide early information about the presence of tumor cells. The tumor marker CA19-9 has been found to be a useful serologic test for monitoring, approving diagnosis, and continuing surveillance for potential spread of recurrence. So let's make a parenthesis here. Don't get confused with your BRCA2. Your BRCA2 gene is a marker, it's a gene marker, it's a genetic marker mutation, okay? That's one thing. The other thing, these are tumor markers. So you have the CEA and you have the CA19-9, which are tumor markers used in the diagnosis of colorectal cancer. CEA, cancer embryonic antigen, is used to detect relapse of colorectal cancer. CA19-9 is a carbohydrate antigen and may be helpful in establishing the nature of pancreatic masses. Okay, so there you go. Abdominal ultrasound and contrast CT scan are most commonly used imaging techniques for confirming a tumor and can be differentiate the tumor from a cyst. Also, the doctor can order endoscopic ultrasonography, the ERCP, the endoscopic retrograde cholangiopancreatography, is going to provide visual diagnostic data. So what interventions are we going to do? So basically, the management for patients with pancreatic cancer is going to try to prevent tumor spread and decreasing pain. So non-surgical management is going to be chemotherapy or radiation. Is used to relieve pain by shrinking the tumor. It may use before, after, or instead of surgery. It could be before the surgery to reduce the tumor, so when they do the surgery, the tumor is already small, or it could be as after or instead of surgery. It all depends on the presentation and also if the patient is eligible for this type of procedures, right? Chemotherapy has a limited success in increasing survival time. Remember that we are having a patient that is losing weight, is not absorbing the nutrients, and that is going to be more difficult after chemotherapy, okay? Anti-angiogenesis factors and kinase inhibitors are a newer group of drugs that focus on cancer cells with little or no effect on healthy cells. So this is the concept anti-angiogenesis. Angiogenesis means that the tumor is creating its own vascularity. Okay, its own network of circulatory, right, blood vessels in order to get nutrients. So these drugs are anti-angiogenesis. These drugs works in avoiding the creation of those blood vessels to get food for the tumor. Okay. Okay, so these drugs are having little or no effect on healthy cells. They are going to work only within the tumor cells. Opioid analgesics also are going to be used in order to control the pain. Intensive external beam radiation therapy to the pancreas may offer pain relief by shrinking tumor cells, alleviating obstruction, and improving food absorption. It does not improve survival rates. And you can see that in every single paragraph there is a remark, right? It does not improve survival rates in terms of chemotherapy, has had limited success in increasing survival rate. The text is telling you somehow that this is a terminal disease, right? For patients experiencing biliary obstruction who are at risk, who are a high survival risk, biliary stents placed percutaneously through the skin may ensure patency to relieve pain. So surgical management is going to be a complete surgical resection of the pancreatic tumor. You are going to have also partial pancreatectomy. Is the preferred surgery for tumors smaller than 3 centimeters in diameter. So it all depends on the presentation, how big is the tumor, where the tumor is located, if it's located in the head of the pancreas, in the body, in the tail of the pancreas, if there are multiple tumors, as we saw in the video, right? So you can understand the decision, how the decision is going to be made based on this. For larger tumors, the surgeon may perform either a radical pancreatectomy, which is going to remove all the pancreas, or the Whipple procedure. We saw already they are going to remove a part of the pancreas, part of the duodenum, the gallbladder, the bile duct, and maybe the part of the pylorus. And with the jejunum, they are going to make certain connections with the stomach, and they are going to try to connect whatever is left part of the pancreas, right? Preoperative care, often in the late stages of pancreatic cancer or before the Whipple procedure, the primary healthcare provider inserts a small catheter into the jejunum. So enteral feedings may be given. This feeding method is preferred to prevent reflux and facilitate absorption. For the laparoscopy procedure, no bowel preparation is needed. However, either approach requires that the patient have nothing by mouth, NPO, right, for at least 6 to 8 hours before the surgery. I would say, since this patient are having in the case of chronic pancreatitis and pancreatic cancer, since they are having awkward levels of glucose, when the patient is going to be NPO for at least 6 to 8 hours before surgery, I will suggest close monitoring of the glucose levels, okay? Because you don't want a patient going through surgery in hypoglycemic event. The Whipple procedure, radical pancreatoduodectomy, is an extensive surgical procedure used most often to treat cancer of the head of the pancreas. We saw the procedure in the video at the beginning of this topic. Post-operative care, observe for multiple potential complications of the open Whipple procedure, and the patient having the laparoscopy Whipple is also less at risk for severe complications. So some common surgical complications includes diabetes, hemorrhage, monitor pulse, blood pressure, skin color. This is normal. Infection, I mean, it's normal care post-procedure. Bowel obstruction, check bowel sounds and stools. That's something different from a regular surgery. Intra-abdominal abscess, monitor temperature, and patient reports severe pain. Immediately after the surgery, the patient is NPO and usually has a nasogastric tube, your NGT, to decompress the stomach. Yes, monitor GI drainage and tube patency. Also monitor the color, consistency, the amount, if it's serosanguineous, the appearance to be clear, colorless, bile, tinker drainage, or frank blood with an increase in output may indicate disruption or leakage of an anastomosis site, and that's very important. That's very important. So here you have the picture of the 3 anastomoses that constitute the Whipple procedure. You see the stomach is going to be attached to the part of the jejunum, the part of the pylorus, right? And then the other part, the other end of the jejunum is going to attach to the pancreas. is going to work as the head of the pancreas. And then you have the choledochojejunectomy, which look for connect the common bile duct to the jejunum as well. So then potential complications of the Whipple procedure, you can have hemorrhage, myocardial infarction. Remember that around these organs there is a lot of vascularity, a lot of veins that are coming from the liver, okay, heart failure, thrombophlebitis, pulmonary complications, atelectasis, pneumonia, all related to the lungs, metabolic complications, unstable diabetes, renal failure, and GI complications, gastric retention, gastric ulceration, gun complications, fistulas, pancreatic, gastric, and biliary. Important to know, drainage from fistulas can cause peritonitis. Take a look at that. Remember that, right? Fistulas can cause peritonitis. And then place the patient in a semi-Fowler position to reduce tension on the suture line and anastomosis size. So semi-Fowler position, stress can be decreased by maintaining the NG tube drainage at a low or high intermittent suction. And then the NG tube also reduces stimulation of the remaining pancreatic tissue. The development of a fistula, an abnormal passageway, is the most common and most serious post-operative complication. That's why I told you that's good to know. Remember that the fistulas can cause peritonitis. These secretions, particularly pancreatic fluid, are corrosive and irritating to the skin, and internal leakage causes chemical peritonitis. Okay, so keep an eye on that and remember that for the exam, because the open Whipple procedure is extensive and can take many hours to complete. Maintaining fluid and electrolyte balance can be difficult. We are talking of a surgery that between 5 and 8 hours on a patient that is having awkward glucose levels. Think about this. So the patient is going to be maybe in a risk for complications. So post-procedure need to be very careful on what to administer. If the patient is sodium, potassium, I don't know, magnesium, calcium, you know, what type of solution, isotonic, lactate, you need to, based on the presentation, the doctor will order all that. In addition, these patients may be malnourished and have low serum levels of protein and albumin on top of everything, right? Which maintain colloidal osmotic pressure within their circulating system. These problems are less likely to occur when minimal invasive surgery is used. So that means you're laparoscopic. Therefore, when possible, the trained surgeon prefers to perform laparoscopic Whipple procedures. So safety, safety, safety. To detect early signs of hypovolemia and prevent shock, closely monitor vital signs for decreased blood pressure, increased heart rate, decreased vascular pressure with a pulmonary artery, and decreased urine output. Be alert for pitting edema of the extremities, depending edema in the sacrum and back, and intake that far exceeds output. Maintain sequestration compression devices to prevent the vein thrombosis. It's extremely important in this type of patient. And maintenance of IV isotonic fluid, as I mentioned before. You need to monitor hemoglobin, hematocrit, you need to monitor albumin, prealbumin, glucose, electrolytes, be ready in case of blood transfusion. The patient may be hyperglycemic, hypoglycemic. This is a complicated case. The stage of progression of pancreatic cancer and available home care resources determine whether the patient can be discharged to home or whether additional care is needed in a skilled nursing facility or with a hospice provider, depending on the patient status, activity, physical activity, and limitations. So that's it. We have finished with pancreatic cancer and chronic pancreatitis. And then there is a couple of questions we need to review, the mastery. Which statement by the client who is prescribed to take pancreatic enzyme replacement indicates a need for further teaching by the nurse? So we are looking for the wrong answer, right? So I need to take the enzymes at every meal with snacks. That's good. After taking the enzymes, I should drink a glass of water. That's good. I should wipe my mouth in case any of the enzymes got on my lips. Okay. I should chew each capsule carefully so it works in my stomach. That's the wrong answer. You don't need to chew the capsule. It needs to go entire, complete capsule all the way to the duodenum, intestine, jejunum, whatever it is. The nurse is planning care for a client who had a laparoscopy Whipple surgery. Okay, for which complication will the nurse assess? So we're going to assess for bleeding, wound infection, intestinal obstruction, of course. Remember, we are altering the regular metabolism and activity when we are removing all these little pieces. Diabetes mellitus, of course, and abdominal abscess. Very good. So those are the answers to these mastery questions. Thank you very much for your attention, and I see you in class to answer the questions you may have related to these topics. It was a pleasure. Thank you so much.